It's a great question, and we see a lot of patients that have keratoconus at Ezekiel Eyes. We also diagnose a lot of patients with keratoconus for the first time. And when we have the conversation with these patients, a lot of the time what they say is they'd never heard of keratoconus before diagnosis. Now, as far as what keratoconus is, I think it's important to go into some of the anatomy behind it. So to put it simply, I'll keep it quite brief. Basically, the front of your eye, you have something called the cornea. And basically, the cornea almost acts like a smooth window that allows us to see clearly. Now, normally, this smooth window is nice and regularly shaped, and there's no bumps in it, there's no notches. It's a nice spherical shape all the way along. Now, what happens in keratoconus is this smooth window starts to become thinner over time. It starts to become a little bit weaker over time. And what happens with that thinning and weakening of the cornea is you get this small sort of protrusion or bulging. And this protrusion and bulging changes the shape of the front of the eye, which changes the way that light interacts with the front of the eye. And it can scatter light and cause things such as distorted vision or blurriness, or you might get halos at night. So to put it simply, it's the thinning and bulging of the front surface of the eye, which causes an irregular surface. Now, as far as why early diagnosis is so important, is because sometimes this condition can progress over time. It's difficult to predict, truth be told, but the main thing why early diagnosis is important because firstly, we can establish baseline measurements. So basically, we get a good picture in time at this date of what the patient's cornea is looking like. We can then get the patient back at another point in time and we can compare those two consecutive measurements and we can see whether or not there's progression. Now, if there is progression, then there is treatment options available to slow down that progression. It's something called corneal collagen cross-linking. We can't determine basically if there is progression if we don't have a baseline measurement. So super, super important. The other thing that makes early diagnosis important is there's behavioural modifications, which we can go through with the patient to try and also stop the condition from getting worse. If you speak to anyone with keratoconus, the first thing they'll tell you is it's really, really important that they don't rub their eyes. So the earlier we pick it up, the earlier we can counsel the patient, the earlier we can get on control, under control allergies that might make them want to rub, and the better the outcomes are as well for those patients.
So the way it's been described to me is that if you think of the cornea as kind of like a soccer ball, which is
Mm.
topical now because the World Cup's on, but if you think of it as a soccer ball, patients with keratoconus, it's more like the pointy end of a rugby ball or an AFL ball. Is that right? Is that close?
Yeah, spot on.
Yeah.
Another really good analogy is if you have a worn tire and it has a weak spot in it, at
Right.
that weak spot, it will start to bulge. So
Mm,
basically, what's happening is at that area in the cornea, it's quite thin. So it's
mm.
bulging forward because it is structurally weaker than the rest of the cornea. But you're spot on there. That's a good analogy.
And so corneal cross-linking is something that an ophthalmic surgeon would do, and you would refer the patient in that case. Is that right?
Yes, exactly. So in order to see an ophthalmologist for corneal collagen cross-linking, in most cases, what they will want to see is that the patient has demonstrated progression. So
Mm,
again, that's why baseline is so important because the first thing we send through to the ophthalmologist when we refer them on is we send them their data. And the first thing they're going to look for in the data is that this keratoconus is getting worse or it's progressing. And if it is progressing, then that's a pretty good indication that if we perform this corneal collagen cross-linking, then it has the potential to slow down this progression. To go into corneal collagen cross-linking a little bit, basically what it involves is there's a sort of vitamin drop. It's vitamin B2 to be specific. The patient will have these vitamin B2 drops placed onto their eye. And then what the ophthalmologist will do is they'll apply some controlled UV light. And the purpose of both of these acting together is basically it strengthens the bonds between that corneal tissue. So the stronger the bonds between the front of the eye are, the harder it is for progression to occur because they're connected to one another more strongly. So that's really, really good for slowing down the progression. The big thing is it's not intended to reverse keratoconus. It doesn't tend to reverse the need for vision correction, but the goal of the cross-linking is to slow down the progression. But outcomes are generally quite good. It does a good job. But again, you need that baseline and you need that evidence of progression to ensure it's going to be worthwhile to send the patient off for that.